Okay, I want to talk about Joining the Dots, which is a publication that the BGS produced back in May of this year. It was led by a Scottish geriatrician called Professor Anne Hendry. Anne worked for a number of years in Lanarkshire and then went on to be an advisor at the Scottish office, and she's currently the Honorary Secretary of the British Geriatric Society. But I want to, and this is really our way of pulling together all the evidence around care of older people and sort of trying to point a direction for the systems across the 4 UK nations, although it's been picked up internationally, actually, about how they might proceed over the next few years. So what I want to cover over the next 20 minutes or so is just give a bit of background. I'm sure the fact that you're all here is an indicator of the fact that you all recognise that an ageing population demands a specific approach, but I want to talk a little bit about why that's the case. I want to talk about how the system in the UK, including Scotland, is currently coping, and then I want to finish by touching on the BGS blueprint as a way forward, and then hopefully we'll have a bit of time for discussion following on from that. I thought I'd pull out some data on Scottish demographics, because Scotland's a little bit different from the rest of the UK, but the underlying message is effectively the same, which is that the population in Scotland is rapidly ageing, and so around about 2000, less than a fifth of the population were over the age of 65. By 2045, that will be close to a quarter. Importantly, in Scotland's case, the number of children at the bottom end of that population pyramid is shrinking. So Scotland has a real issue with the fact that the population is ageing and the youth coming through are not going to be able to keep up with that process. So what that means is the shape of the population is going to change over time, okay? And this is what we used to be called a population pyramid, although in most parts of the world they've stopped being pyramid shaped. It used to be that all the young people were at the bottom and there were very few old people at the top. But what you can see here is age up the y-axis at the left-hand side, and the number of people in each category, males and females, along the x-axis along the bottom, okay? And what you can see is that the population in green in 2020 has a big bulge round about the bottom in the middle, and as we move towards 2045, that bulge is moving upwards with fewer people at the bottom in order to support it, okay? And that means fewer people to pay taxes in order to pay for the care that we deliver, which means that our health services and social care services will be even more stretched, but it also means fewer people to provide practical care. So there will be workforce challenges going forward, and there will also be challenges to family caring. And as I mentioned before, Scotland is even more challenged than other parts of the UK because the Scottish population is going to shrink, and that's because Scotland is going to have more net emigration, people leaving Scotland, than other parts of the UK. So England and Wales in particular can count on lots of young people coming to the countries from other parts of the world that will make up the workforce and will make up the young population. That's less of the case for Scotland. So if anything, Scotland's got to be even cannier about how it plans for care of older people than the other 4 UK nations. Now, I think it's important when you read about this in the newspaper, it's often referred to as kind of a silver tsunami. It's a kind of tidal wave that's going to overwhelm us. And I think it's really important for us as people that is working in this space to remind ourselves that actually population ageing is a source for celebration. It's not all bad. A silver tsunami is a wrong word. Des O'Neill is an Irish geriatrician, professor of geriatric medicine at Trinity College in Dublin, and he reminds us in important paper in Age and Aging, that there's no upsides to tsunami, everybody loses. But actually, there's lots of upsides to an ageing population. Older people are a very productive part of society. They volunteer on a regular basis. They do the majority of informal caring, and they also are valued friends, valued family members, and we want people to live for as long as possible and as much quality of life as possible. So let's not get negative about this. It's something to celebrate. And if an ageing population poses challenges to our systems and services, the problems are with our systems and services, not with the older population. Having said that, there are some challenges that come with an older population. And this is a table that comes from a paper published in Age and Aging, which is at the major journal of the British Geriatric Society back in 2018. And this is a bit of population modelling, looking at multimorbidity, people that have more than one condition. And you can see towards the left-hand side of the table, that's the number of conditions that people have: none, 1, 2, 3, 4 or more, 2 or more. And at the right-hand side, and I've highlighted this in red, is the percentage change between 2015 and 2025 and 2015 and 2035, okay? And what you can see is a rapid increase in the number of people that have 3 or more conditions and the number of people that have 4 or more conditions, okay? So it's not aging that's the problem. It is multimorbidity, multiple long-term conditions, it's the problem, and the long-term consequence of multimorbidity is frailty, which is what you are here to discuss today. So rapid increase in people living with multiple long-term conditions and rapid increase in the number of people living with frailty, which challenges our systems because our systems as they are currently designed are not fit for purpose. So what does care for older people currently look like? Now, I don't want to be completely pessimistic. I'm going to end this talk by talking about what we can all do to make things better, and that's what you are here to sort of work on as part of this, collaborative that you're participating in just now. But I think you would all accuse me of being deeply unrealistic if I pretended that everything was completely rose-tinted at present. It's not. Okay, now I often start with this data, which is English data, okay, which is looking at the number of older people who spend more than 12 hours in accident emergency departments in England following a decision to admit. So these are people who are sick, they come to hospital, they're so sick that they need to come into hospital, and then they wait 12 hours or more in order to get into the medical admissions unit and up to the wards, okay? Now the target in England, there is a similar target in Scotland, is that people should not be waiting more than 12 hours. And what you can see over the period since the pandemic is a rapid increase in the number of people that are waiting 12 hours or more in England. And we reached an all-time high in December 22-23. Okay, now this graph looks a little bit reassuring towards the end and that things start to tail off again. But I can tell you right now that I looked at the statistics again last week, and we are in exactly the same position with these weights as we were in September 2022. So we're not in a terribly better position in England going into this winter. And it doesn't matter what metric you look at across the system in England, whether it's ambulance waits, whether it's 4-hour waits in emergency, 12-hour waits in emergency, delayed transfer of cares when people are medically stable for discharge from hospital. They're all the same, and they're all the worst they have ever been last winter, and they all look pretty much the same this September as they did last September. Scotland is obviously better, but the truth of the matter is it's not really. And these are equivalent data from Public Health Scotland, which show that the graphs for Scotland look pretty much the same. Okay, it's not as bad as England, but it's the trends overall are the same, and we're seeing performance which is probably the worst we've ever seen across the system during winter last year, despite the very, very hard effort that we're all putting in at the coalface. And this was in the newspaper just yesterday. People say sometimes, why do I leave my presentations to the last minute? The answer is there's always breaking news just before I want to come on and do my talk. This was data that was in the newspapers just yesterday. I'm sure you all saw it in the evening news. I saw it even in the evening news down here south of the border. Data about the number of people waiting 24 hours or more in accident emergency departments across Scotland, an all-time high over the last year. That's data from the Royal College of Emergency Medicine. So they're relatively responsible reporters of these types of data, and they're doing that to shine a light on the fact that we all need to be laser focused on how we deliver services going into this winter if we're to avoid further deterioration and a repeat of what we went through last year. So systems pretty desperate in England, not quite so bad in Scotland, but you're still facing some very substantial challenges. Older people are most likely to be affected by these system challenges. So this is data, it's English data, but you can produce similar data for Scotland. And this comes again from the Royal College of Emergency Medicine. It was published in the Guardian newspaper earlier this year. And this was older people, their weights in Category 1 emergency departments. The graph in grey is 2021. The graphs in red is 2022. And what you can see that in 2021, people who were aged 80 and over had an average 9-hour wait in the emergency department, already more than double what people who were under 20 experienced by way of waits. But by the time we got to 2022, that had more than doubled, and the oldest population saw the greatest increase in waits in emergency departments. So when we talk about systems pressures, it's older people with frailty who are most adversely affected. Why is this happening? Well, the emergency department is the canary in the coal mine. Okay, it's not the problem. The system design issue is not in how we deliver emergency medicine. There are some things we could do better in the emergency department, but that's not where the majority of the problem lies. And in England, the case is that it's certainly in social care and in rehabilitation where the problem lies. And there's some signal, although you might want to ask me about this when we get to talks, to questions, the problems lie in similar areas in Scotland. Okay, this is another Guardian article which was reporting workforce data from the social care workforce in England, which reported that 2.6 million older people in England had unmet care needs. This was at the beginning of this year. That's 1 in 5 over 80s, and that correlates with 165,000 vacancies across social care, both care homes and domiciliary care in England, and that's a 50% increase since 2020. Okay, now the workforce data is a bit more mixed for Scotland, but there's still some very concerning signals that you're facing similar workforce shortages, and that's causing similar pressures, which is having knock-on effects for the acute system. So how do we fix this? Well, older people with frailty lie at the heart of the problem, as I've described it. They are the ones most likely to be adversely affected, because they are the people that are backed up in emergency departments, awaiting transfer of care out into rehabilitation and domiciliary care in the community. They lie at the heart of the sort of system collapse that we saw certainly in England last winter. And if we can get care for older people right, then the system will be in a much better position to provide healthcare for all of us. And so we published 2 documents around this in the last year. The first we published on the 10th of January 2023. That was called Protecting the Rights of Older People to Health and Social Care. That had 7 immediate focuses for health and social care systems across the UK. You'll see that the Royal College of Physicians of Edinburgh was one of the organisations that co-sponsored that document with the BGS. We're in the process of drafting it again for this winter. The recommendations haven't changed substantially, and this year we have both Royal Colleges of Physicians in Scotland, Edinburgh and Glasgow, signing up to that document, showing that they agree with all of the 7 recommendations that we made in it. That's to get us through this winter. Longer term, the document, its the main focus is the BGS blueprint, which we've called Joining the Dots. Now, as I said, it was led by Anne Hendry, who's a Scottish geriatrician. We wrote this using the language of commissioning, but we don't mean commissioning with a capital C in the way that we commission healthcare because there's a purchaser-provider split in England. We mean effectively someone in every system's got to decide where we focus our priorities. In Scotland, they might not be called commissioners, but they are still effectively commissioning healthcare. So we made this with the people who were designing and delivering services in mind. And so there's some stuff here that's kind of some quite high level stuff, but there's also some stuff about how we actually deliver services on the ground. We started this work by some consultation work with older people, and we went and did some work for the applied research collaboration in Yorkshire and the Humber, and we asked older people what mattered most to them. And none of this will surprise you. Yeah, they wanted to stay in their own home for as long as possible with support if they needed it. They wanted to stay independent with a focus on maintaining their daily and social activities. They wanted to make decisions with family, friends, carers, professionals. They wanted to have joined up care. They wanted for their health and social care professionals to understand their experiences better. They wanted a better understanding of their own physical and mental health conditions. They wanted to have more information about their physical and mental health conditions. They wanted to worry less about falling. They wanted to be able to do more exercise and physical activity. They wanted to have better support for vision loss and impaired vision. And they wanted to have a range of housing choices so that they could stay where they wanted with the care they wanted for as long as possible. And a lot of that's not very health centric. It's not about how long they spend in hospital. It's not about discharge from hospital. It's not about the format of how their healthcare is delivered. It's about allowing them to be as normal as possible for as long as possible, giving them as much information as possible, and giving them what some people have called voice, choice, and control over the care that they receive. Okay, so that's what older people are telling us that they want and need. Okay, and so how do we deliver that? Well, when we wrote Joining the Dots, we had 7 system touch points and 12 recommendations. The 7 system touch points are the ones that I've outlined here. The overarching focus being on enabling independence and promoting well-being, moving away from this very health-centric language around conditions, around morbidity, and focusing instead upon what it is that people want to achieve in their lives and thinking about how we structure services to deliver that. We talk about a focus on proactive anticipatory care, working with people to work out what their priorities are and to deliver the healthcare they need in a proactive way in order to meet those goals rather than reacting all the time. Yeah, if we always do what we've always done, we're always going to get what we always got. We have to change to something different. So we need to be focusing on anticipatory care more. There is now on the slate a proactive care plan from NHS England, and I believe there are similar documents underway from Scotland, but that's going to be community led. It's going to be around individualised discussion with older people, and it's going to be trying to make sure that people have care plans in place in advance rather than waiting for things to go wrong. There's a focus on urgent community response, reablement, rehab and intermediate care. So that's step up care and step down care, ensuring that everybody can have multidisciplinary input with a focus on maintaining independence and maximising functional abilities. There is a focus on frailty attuned hospital care. We talk about front door frailty as part of that and frailty care in the emergency department, but we also talk about things like orthogeriatric surgical liaison, and we also talk about making sure that we prevent deconditioning for older people when they come into hospital and that we recognise delirium. We talk about reimagining outpatient and ambulatory care to make sure that it's frailty attuned, that people only come in for outpatient appointments when they need to come in for outpatient appointments, that care goes to them more frequently, and that we reduce the number of contacts to take account for the fact that it's often difficult for people to travel to specialist care. There's a focus around enhanced healthcare support for long-term care, what we in England call enhanced health and care homes. And then there's a focus around coordinated, compassionate end-of-life care, recognising when people with frailty are dying and making sure that we have the support in place to enable them to do so in a dignified way. When we look at the recommendations, there are 3 that focus around systems leadership, and this is about making sure that we have people at a very senior level in organisations focused on delivering care for frail older people. So we talk about having a senior officer or non-executive board member with a specific role within organisations to support health and social care for older people, and that they have data at their fingertips that enable them to understand how their systems are performing. And I'm sure that as part of this quality improvement Collaborative, you're looking a lot at how you get really good data. I guess one of the questions you might ask yourself is that data feeding up to the senior decision makers in your organisation? And if not, why not? And how do you get it in front of them? There's a bit around workforce and training, making sure that people have the skills they need in order to be able to deliver comprehensive geriatric assessment, by which we mean multidisciplinary proactive care for older people, and making sure that you have the right mix of skills in your organisations in order to be able to deliver effective care for older people. And again, I'm sure that you're looking at that as part of the current improvement collaborative you're working on, making sure you've got the right people in the room and that they're all equipped with the training and expertise you need in order to be able to deliver the care that older people require. There's a specific focus in this document on protecting and preserving the right to rehabilitation for older people. In England, at least, and there's maybe less of this in Scotland, there's been a trend over the past 2 decades for us to close the old school rehabilitation hospitals, and that's probably appropriate, but we haven't reinvested in rehabilitation in the community at anything like the rate we should have done in order to make sure that everybody has a right to recovery following acute illness. And we are doing a bit of campaigning around this at the British Geriatric Society, and we plan to issue a follow-up document on how to structure rehabilitation for older people, and that will appear in the summer or autumn of 2024. Anne Hendry again is leading on that document. There's a piece of work around how we make sure that the voice of older people is protected at an organisational level. Are we consulting older people, their carers and their communities as equal partners when we're designing and delivering and monitoring the impact of health and social care services? And if not, why not? Are we making sure that we're providing support for older people to deliver their lived experience as part of how we design and deliver services? And again, I'm sure that's a focus as part of your quality improvement collaborative, and making sure that you're working with the stakeholders who are receiving the care that you're delivering. Finally, there's a focus on making sure that we integrate our approach across health and social care. Scotland is light years ahead of the rest of the UK when it comes to integration. I'm sure you still have some way to go, but it is very reassuring that to see that there's both social care and healthcare representation in the room with you there today. And I think it's constantly reminding ourselves that we don't always speak the same language or even think the same way about problems, and making time in our daily schedules to listen to each other, reflect on what each other has got to say, and to learn from each other's expertise. Yeah, and health colleagues in particular often forget how dominant they are in a lot of discourses, how much power they have in a lot of discourses, and it's really important for us to just pipe down and listen to our social care colleagues when we're designing and delivering services. Yeah. Pipe down, that is a thing, isn't it? Yeah. Finally, we trail the fact that we have a lot of existing resources and guidelines within the BGS, and we also invite people to use the expertise held particularly within the special interest groups of the British Geriatric Society. We're a 4-nation organisation. We had an amazing meeting in Glasgow last week, and if you're not a member of the BGS, please consider joining. We have 4,800 members at present. We're a multidisciplinary organisation. Our fastest growing membership categories are nurses, general practitioners and allied health professionals. We also now have care home staff amongst our membership. The sort of things that we offer through the BGS are this document here, the Frailty Hub, which brings together all of our learning and all of the evidence on frailty, and actually includes some really excellent online CPD and e-learning resources around frailty. That's currently free and is paid for by NHS England, and we've got no plan to start charging for that in the near future. So you can access that either through the link there or through the QR code. We have a quality improvement hub, which is currently only available to the membership, but it might be helpful to some of you as you're working for your quality improvement collaboratives, and helps to support and supplement some of the materials that are available through Health Innovation Scotland. We have really important policy documents, and I spoke before about enhanced health and care homes. Ambitions for Change is the document we produce to say really how do we deliver healthcare for care homes on the ground, and this is free to access for non-members, and you can get it from the BGS website. And we're also doing a lot of work around canvassing for a change in the workforce structure at the moment. We started this earlier this year with our More Geriatricians document. We decided to start with the workforce group that we had the most information about. And we had lots of data from the annual Royal College of Physicians census about geriatrician numbers. But I'm sitting down in the next couple of weeks with the Chartered Society of Physiotherapy, the Royal College of Occupational Therapy and the RCN to discuss how we do this for other professional groups. So those resources are at your disposal as well. So to conclude, and I think I'm just in time, we currently struggle to provide effective care for older people in most parts of the UK, possibly slightly better in Scotland, possibly not. The system won't work for everybody else until it works for older people. So what you're doing by being in this room today is absolutely essential to everybody who receives health and social care across the system, no matter how old they are. We at the BGS have laid out core principles of service design in the BGS blueprint, and we are now going to use this as a scaffold upon which to build further campaigns around rehabilitation, around workforce to improve care for older people. And we hope that you can use it in your day-to-day improvement work as part of this programme that you're involved in at present. I will stop there.
So it just remains for me to thank you, Adam, so much for sparing up this hour to join us in Scotland. You've certainly given us food for thought about listening, about using data and recommendations to influence change further up the chain, so that we can promote frailty management, older adults in Scotland. So thank you so much, Adam. One more round of applause.